Good afternoon and welcome to our webinar, Opioids, Addiction, and Alternatives. We're very happy that you could join us. My name is Amy Gall, and I'm the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. A few pieces of housekeeping before we get started. An hour after this webinar ends, you will receive an email with a link to a post-program evaluation. We ask that you complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Be sure to note on your survey if you would like CADC, nursing, or social work credit. Certificates of completion will be sent as an email within 1 week of today. This program is being recorded and will be available on the Partnership's YouTube channel until June 24th, 2022. We will be muting all attendees' microphones during the presentation, but we would be happy to have questions and comments from you. Please write them in the question box, and at the end of the webinar, the speaker will respond to as many as possible. And now I'd like to introduce our speaker, Judith King. Judith is a master's prepared social worker who has worked in the field of addictions for over 30 years. She holds a BA in early childhood education, and she received her MSW in group work sequence from Rutgers University School of Social Work. Aside from her certification as a licensed clinical social worker, Judith is also an FASD educator, licensed clinical alcohol and drug counselor, and a certified perinatal addiction specialist. She currently works at the Partnership for Maternal and Child Health of Northern New Jersey as the manager for our Perinatal Addictions Prevention Project. Welcome, Judy.
Thank you, Amy, and welcome everybody, and thank you for attending our webinar today. Today we're going to be looking at prescription and non-prescription opioids, the high potential for addiction, and the ways that many opioids wind up in the illicit market. We'll also discuss medication and non-medication alternatives to opioids. So at the conclusion of this program, participants will gain knowledge about addiction and alternatives and use that knowledge in their professional practice. It's already discussed this with you. So how many deaths do you believe occurred in 2017 because of an opioid overdose? So in 2017, there were over 47,000 deaths due to an opioid overdose. And you can see from 2015 to 2016 to 2017, there was an increase. In 2018, 46,802 opioid deaths occurred. Although the number seems a little slightly lower than the previous year, we have to keep in mind that New Jersey is one of 5 states where opioid overdoses actually increased. Drug overdose is the leading cause of injury-related deaths in the U.S. According to the CDC, 67,367 individuals died of a drug overdose, and 70% of those involved an opioid. In 2017, we had 217 million prescriptions written for opioids. In 2018, we had 168,159,000 opioid prescriptions that were written. So we see that there's a little bit of decrease. So how do they work? Opioids bind with the opioid receptors in the brain and in the respiratory and cardiovascular systems. And it prevents the body from receiving pain signals and also releases dopamine, which stimulates pleasure. Opioids are depressants, and they slow down many functions of the body, such as breathing and heart rate. Repeated use can result in physical and psychological dependence. We know that there are many medical reasons and legitimate reasons that a prescription for an opiate might be indicated. Some of them include cancer, surgery. Certainly, if you've had a surgery, you may need an opioid for the pain after that surgery. You have to be careful that, again, they're given for the shortest amount of time, because even a prescription opiate can result in becoming dependent on them. There are natural opiates that are derived from the poppy plant, such as morphine and codeine. They're sometimes referred to as opiates, and there are synthetic opioids that kind of mimic the opiates. But for our purposes, we're going to refer to all of them as opioids. There are side effects. You can have shortness of breath, constipation. Sometimes you see commercials for people that are taking a prescription opioid and how they have to deal with the constipation. There's also drowsiness, the nodding. Heroin addicts who use a lot of heroin have the heroin nod, where their head will go down and then jerk back up, and go down and jerk back up, and it's the heroin nod. So 4 to 6% of individuals who misuse prescription opioids, and then the doctor just stops their prescription, they'll often will switch to the less expensive heroin. They're addicted to it. And if they try and go out on the streets, these pills can be $10, $20, $30 a piece. So they will switch to the less expensive heroin. About 80% of heroin users first misused a prescription. Heroin users are no longer those that we usually think about as a heroin addict on the streets or in an abandoned building and with those track marks. Now we see that it might be the high school athlete who was injured and given an opioid and became addicted. Even though they might be using it as prescribed, you can still become addicted to it. It might be the soccer mom who broke her ankle and had to have surgery on it and was given an opioid. So individuals that you never thought would be a heroin addict are now abusing heroin. Heroin can be a white powder, a brown powder, or a black tarry substance. The black tarry substance usually comes from Mexico, has a lower percentage of heroin in it, but it's real easy to produce, so that's why some of it winds up on the streets. Heroin can be injected, smoked, or snorted. Individuals who don't want you to know that they're using heroin and they want to use it IV, they will sometimes inject between their toes or between their fingers so that you're not seeing those telltale track marks in the crook of your arm. Now, fentanyl is even more potent than heroin. It's a very, very potent opioid, and it's responsible for many overdose deaths. And if you can see from the picture there, you can see the amount of heroin, and you can barely see the granules of the fentanyl, which is the same amount. And oftentimes fentanyl is mixed with heroin, and this causes the overdose because people don't know that the fentanyl is in there. And the overdose deaths for fentanyl have increased by 10% from 2017 to 2018. And an overdose can actually occur even if you handle the fentanyl. It can be absorbed through your skin, and you can have an overdose. Fentanyl tablets have been found on the streets that were mislabeled, some of them labeled as oxycodone. So sometimes people don't know they're taking the fentanyl, and this is what causes some of the overdose. So the Diagnostic and Statistical Manual of Psychiatric Disorders, or DSM-5, lists the signs and symptoms of an opioid use disorder. It includes tolerance, where you need more and more amounts for longer periods of time, obsessing about the drug. Where am I going to get my next high from? And it causing negative effects on your work, on your school, and on your family relationships. Continued use, regardless of the negative effects that it has with interpersonal relationships. Family, your friends, what these relationships are impacted by your use. Loss of social activities. You stop doing everything that you used to like to do. Having physical problems like constipation or an abscess if you're using IV, or trouble breathing. If an individual has 2 or 3 of those symptoms, it's considered a mild opioid use disorder. If they have 4 or 5 of the symptoms that are listed, that's considered a moderate opiate use disorder. And more than 6 of the list of symptoms, then it's considered a severe opioid use disorder. Stopping an opioid can lead to withdrawal. The kind of opioid used, the amount, and the duration of use can determine when the withdrawal will begin and how long it will last. So some of them can last a week or more. Some of them may be less than that. So withdrawal symptoms can, and they're very severe physical discomfort. You can have stomach cramping and diarrhea and sweating and sometimes chills and vomiting. Usually a medical detox is needed for withdrawal from an opioid, or medication-assisted treatment, which we'll discuss in a little while. Some individuals will actually go back to using their opioid because they want to alleviate these severe withdrawal symptoms. So remission, recovery. Again, the DSM-5 has kind of categorized it that there's different levels. So if an individual has not met any of the criteria for an opioid use disorder and hasn't used for 3 months, then it's early remission. If they are symptom-free and drug-free for 12 months or more, then you have sustained remission. Again, we'll be talking a lot about maintenance therapy and in just a couple minutes. So let's talk a little bit about how some of these prescription drugs wind up on the streets. We know that some are manufactured, or some of the fentanyl is illegally manufactured, and that's what's on the streets. It's medically used, but there are a lot that are manufactured. But there's a lot of things that are diverted from the legal use. And some of the reasons for these diversions are they want to use it themselves. They want to make some money. You can see that it's a $25 billion a year industry for those street drugs. Maybe addicted to it, or you might be self-medicating. Now, doctors and nurses and pharmacists have more access to prescription medication. And sometimes some of the ways that some of this prescription medication can wind up on the streets is there might be a theft in the hospital. It could be a doctor, a nurse, an orderly who gets into the medical cabinet, the medicine cabinet, and takes some pills out of there. The same thing can happen in a physician's office. There's also shorting medication to the patient. If the patient is supposed to have 3 pills of something, you only give the patient 2 and you pocket 1. These are the kinds of things, you're shorting the patient. But nurses, doctors, physicians, pharmacists are not the only ones who divert these to the street. Drug manufacturing. You have drug companies that manufacture all of these drugs, and sometimes the thefts can happen at the manufacturing level. Once the drug companies have manufactured the drugs, they have to be transported. They have to wind their way to the pharmacies who are prescribing them or dispensing them. So there can be some theft in that transportation of it. There can be forged or stolen prescriptions or altered. I had a client, this about 20 years ago, was a nurse, had been in a very, very severe accident. Her legs were very mangled, and they didn't think she would ever walk again. So she was on an opioid prescription for a long period of time, and then the doctor just stopped and said, "You've been on it long enough." Well, of course, she was already addicted to it, and so she stole a prescription pad and started writing out prescriptions. Unfortunately, she got caught because the prescription pad that she stole was from a doctor who had passed away, and the pharmacist knew that, and that's how she got caught. But there are other times, it might say, okay, a 5-day supply, and somebody can put a 2 in front of it. So now you have a 25-day supply. I know some of the ways that they are trying to prevent these kinds of things. A lot of doctors don't give paper prescriptions anymore. A lot of doctors are, what pharmacy do you want to go to? And electronically they send the prescription out, which kind of helps prevent some of that from happening. We do have some doctors, and thank God they are few and far between, but there are some doctors that will just indiscriminately prescribe opiates without really there being a reason for it. There's doctor shopping where people will go to several doctors with the same complaint, trying to get more than one prescription, and we'll talk a little bit about how that is being handled, that is not as easy to do anymore. And then, of course, the illegal sale by healthcare providers. So homeowners, if you are selling your house and you have an open house, individuals that are drug seeking will go to these open houses and go to the medicine chest and see what drugs are in there and what drugs they can take and steal. So the best thing if somebody is selling their house is to get a lockbox and put all the medication in a lockbox so it cannot be stolen by somebody that's wandering through your house at an open house. In pharmacy, there's a lot of theft that goes on. Again, can be shorting a prescription. How many of you count your pills when you get your prescription home? Do you dump it out and count your pills? So sometimes they may short you 2 or 3 pills, but if they do that with every prescription, that can amount to a lot that is being diverted to the streets. Now, it may be the pharmacist or it may be an employee. You know, a lot of pharmacies, the pharmacist is behind the counter, but who's at the register? You know, a high school student, a college student, or a mom who's working while her kids are in school. So there's a lot of other people that have access to those prescriptions. Outside thefts. These are about 6,500 pharmacy thefts happen every year, and they can be by armed robberies during the day, or breaking into the pharmacy at night and stealing the pills. All of these thefts have to be reported to the DEA, and pharmacists in New Jersey have to report to the state how many opioid prescriptions they filled through the prescription monitoring program. So Narcan is medication that can reverse an overdose. Usually, a lot of family members will get the nasal spray and may go to some training, some Narcan training. And during COVID, a lot of these Narcan trainings are actually online. And if you go to the training, they usually get the nasal spray. And as far as I understand, you can get these from the pharmacies without a prescription if you need them. Now, certified professionals can use an IV. So it's packaged in 2 doses. So if the first dose is not effective, a second dose can be given in 2 to 3 minutes. You need to call 911 immediately. There's not enough research on Narcan and pregnancy and breastfeeding. However, if you have a pregnant mom who's overdosed, you're going to use the Narcan to save her life. You're not going to worry about, well, if I give it to her, what's it going to do to the baby? You want to save her life. That's the primary objective. So medicated assisted treatment, or MAT, is an effective treatment for opioid or narcotic addiction. Buprenorphine, it's no longer Subutex, and then Suboxone and Withdrawal, which we will talk about. So Methadone can be in liquid or pill form and has been the standard treatment for years and is FDA approved. It prevents withdrawal and cravings, doesn't cause drowsiness, and allows the person to work and function. And it helps restore the brain function. It can be used as a maintenance, and some individuals need it for a long period of time, and some individuals even stay on it for the rest of their life. Or you can use it for a short period of time and decide if you want to slowly detox off of it. It's important that counseling be part of the treatment. You can stop your use, but counseling helps you change how you deal with stress. It changes people, places, and things. And you learn about relapse triggers and relapse prevention and how to change your behavior. Recovery is not just stopping the drugs, it's a lot of behavior changes too. Buprenorphine is another FDA-approved treatment for opioid use disorders, and it began in about year 2000. It has a lower abuse potential than methadone, and many methadone clinics are now making this an option. Private physicians who are certified with special training can also prescribe it, so you can get this from your private physician. One of the drawbacks with buprenorphine is that it has a ceiling effect. So you can only give up to a certain amount, and then if you try and give more, it's not going to make any difference. Where with methadone, if it's not helping with your cravings, they can keep increasing the dose. With buprenorphine, you only can go so far with it, and then it doesn't make any difference. The other thing with the buprenorphine is that you have to be opioid free before you begin using it. Buprenorphine works by linking to the opioid receptors in the brain. The tablet is placed under the tongue, but just like any other drug, it can be abused. If it's crushed, the pill can be snorted or injected. And the Subutex brand has been discontinued, and now it's really just generic things that are available. Probufenine, if I'm saying that right, but it's an extended medication of buprenorphine, and it consists of implanting 4 implants in your arm about 1 inch apart, and it's slow release of buprenorphine for 6 months. So it eliminates having to go for daily dosing. So naloxone is buprenorphine that is combined with naloxone. You won't feel the naloxone if it's taken under the tongue. But if it's crushed and snorted or injected, the naloxone will block the pleasure feelings. It should not be used by pregnant women because the naloxone can cause birth defects. Suboxone is also available in a film that's placed under the tongue, and it's prescribed, can be prescribed by your doctor, and it's important to not drink alcohol while you're using this. Withdrawal is injected once a month by a qualified physician or psychiatrist. It's used to prevent relapse after detox. So the problem with this is that you need to be opioid free for 7 to 14 days before you can start this. So if you've gone to detox and you've been opioid free for 7 days, then you can start it. Now, this is used, it can also be used for alcohol dependent. That's where it really kind of started. And like any drug, it can have some side effects. The nausea, maybe at the beginning when you first start using this, you may feel nauseous, but it tends to go away the more you use it. But there can be headache, dizziness, depression, and muscle cramps. So they're just like anything else. Now, not everybody feels all of the side effects. These are the possible ones. Some may feel 1 or 2, some may feel none of them. So let's talk about some alternatives to opioids. There are non-opioid medications that can treat nerve and tissue damage. Tylenol is used for headaches, fever, back pain, and arthritis. But care needs to be taken since large amounts of Tylenol can cause liver damage. Other alternatives. Non-opioid medications, both over-the-counter and prescription NSAIDs, such as Advil, Motrin, and Voltaren, can be used for mild to moderate soft tissue damage, like arthritis, sprains, and headaches and fevers. Over-the-counter NSAIDs can be taken with prescription opioids. Caution should be used as extended use can cause stomach issues like gastric bleeding. And this is particularly with seniors. Celebrex is a newer NSAID prescription with a lower risk of stomach problems. There are also topical treatments, such as lidocaine, creams or patches, capsaicin. So these are some of the things that you can use that are non-opioids that would help with pain management. Now, it's unclear how well anticonvulsants work for nerve damage. They're dangerous if taken with your opioids. Now, one that has been used for diabetes, shingles, but mostly for seizures. And Lyrica has been abused. And those that abuse Lyrica call them Johnnies. So again, you have to be careful as any medication can be abused. Antidepressants such as Elavil and Tofranil can be used for depression and for sleep difficulties due to pain. They should be taken daily, regardless of the pain level. And again, you may use a lower dose than if you were dosing for depression, lower dose for the sleeping difficulties. Their side effects may be dry mouth, but drink a lot of water, and it could cause some constipation too. Muscle relaxants can be used for muscle spasms. Serotonin and norepinephrine reuptake inhibitors like Cymbalta can be used for fibromyalgia or musculoskeletal pain. Nerve blocks are corticosteroid injections used to decrease pain and inflammation. And it can be done under X-ray guidance. And it usually involves like 3 injections. And these can tend to last a long time. Long-lasting effects the pain stays away for a long time. Facet joint block is an injection of a local anesthetic to one or more small joints along the side of each vertebrae on both sides of the spine in the lower back. It is always done under X-ray guidance. The lumbar sympathetic block is an injection of medication that helps relieve lower back or leg pain. The celiac plexus blocks are injections of pain medication to help relieve abdominal pain, commonly associated with cancer or pancreatitis. The celiac plexus is a bundle of nerves that surround the aorta, the main artery into the abdomen. The stellate ganglion block is an injection of a local anesthetic to block the sympathetic located on each side of the voice box. It can be used to relieve head, neck, upper arm, or upper chest pain. And it also helps increase circulation and blood supply to the arm. Nitrous oxide, or laughing gas, is used for sedation and pain. And if it's approved by the doctor, this can be self-administered. Now, your corticosteroid injections involve cortisone shots being into your usually to relieve pain and inflammation in specific areas of the body. So you might get a cortisone shot in your shoulder if you have some shoulder pain. I've gotten cortisone injections in my knees for my arthritis. So it's specific to a specific area that you have that. So the American College of Physicians, the U.S. Department of Veterans Affairs, and the Center for Disease Control, the CDC, recommend non-drug treatment as the first course of action for persistent pain. Now, we're not talking about surgical pain. We're talking about just, arthritis or, those kinds of things that may, sprained ankle or a sprained wrist. So ice packs and heat can be used to ease pain. Your physician, your nurse practitioner can let you know which is better for your type of pain. So usually the ice is used if you have like something that's swollen and you want to decrease that, and heat is sometimes used to relax your muscles. But I would check with your healthcare provider to see which one works for your pain. And it's important to stay physically active even with pain. It can assist with circulation. So again, exercise as much as you can with your pain. If there's a lot of pain, you know, it might be very moderate and very low impact exercise, but sometimes it's better than just sitting and letting everything stiffen up. And of course, physical therapy with a trained professional can help assist with your pain too. Other alternatives that also require a trained professional include your occupational therapy. This helps you with your daily routines. How are you going to manage if you've got shoulder pain, or you know, what are you going to do? How are you going to dress? How are you going to fix your meals? These kinds of things. This is what occupational therapy does. Acupuncture, I would make sure that you get a certified acupuncturist. Somebody's going to put needles in your body. You want to make sure they know a lot about the body and they know exactly what they're doing. Same thing with a chiropractor. Make sure that you have a certified chiropractor who has been trained in all the circulation in your body and those kinds of things. And you know, adjustments sometimes will help ease some of the pain. Biofeedback is another alternative. You use a machine. I think you need to be with someone who has been trained on these machines. I know that it has been used in the past with addiction, biofeedback, but it helps control the body's response to pain. You can also use relaxation techniques such as guided imagery, breathing techniques. The partnership has a PSA on breathing techniques that might be helpful for anyone who would like to learn how to do breathing exercises for relaxation. And it can also be hypnosis. Psychotherapy might be very important too. It doesn't stop the pain, but it helps an individual deal with the pain and learn how to have a better quality of life regardless of the pain. Oh, did I skip one? Okay. So a therapeutic massage also helps. And again, you want to make sure that you have somebody that may be qualified to do that massage. If it's just a little bit of pain, you might have one of your family members give you a little bit of massage, but make sure that you're not doing more harm than good. Same thing with yoga. You might be able to take a yoga class if it wasn't for COVID. So for right now, you might want to get a DVD or on TV and learn how to do the yoga by yourself. But again, make sure that that you're not doing more than you can. There's a lot of yoga positions that might not be the best for you. You have to figure out what's going to be good for you. Water, aquatherapy. Whether you're in a pool or in a hot tub, sometimes that can relieve some of your pain. If it's excessive pain, you might want to work with a physical therapist in a pool. Transcutaneous electrical nerve stimulation is a non-invasive stimulation. Electrical currents are delivered through the skin where it releases endorphins to stop the pain signal to the brain. Ultrasound has been used for decades. It uses sound waves to treat inflammation from things like sprains or tendinitis or bursitis. Iontophoresis, and I apologize if I've mispronounced that, but this is an electrical current that will pass through the skin that's been soaked in tap water, saline, or medications, which allows the ionized particles to cross the skin barrier to reduce inflammation. Low-level laser therapy, or cold laser therapy, utilizes a laser to penetrate the skin to alleviate pain. There are a variety of pain relieving devices on the market that help soothe aches and pains. There are types of machines or kits. I even saw one online that was a kit to help with menstrual pain. So there are those kinds of things. Braces. We know that if someone has a sprained wrist or ankle or problems with their knees or their shoulders, there's all kinds of braces out there that can help with the alleviating of some of that pain. Canes can be used. I would just urge that you make sure that the cane isn't so short that you're bending over and you're doing more harm to your back than is necessary. Walkers may be needed if you've had any knee replacement or hip replacements or some other kind of surgery where it's a little bit harder to walk. You may need a walker for a while. Orthotics. There are orthotics over the counter, but if they don't work, go to a podiatrist and get a prescription orthotic. So it's important to note that for nurses, there's a recovery and monitoring program available to you. It's a 24-hour hotline that you can call. It's confidential and voluntary, and it's meant so that a nurse who may have, for whatever reason, become addicted to an opioid or another substance, they can get help before their use kind of impacts on the safety of their patients. So there are other resources available for nurses or non-nurses. So there's a National Drug Hotline. There's helplines. There's also a treatment directory that's available online for New Jersey from the Department of Human Services. And then there are support groups. There are 12-step programs, AA, MA, Al-Anon, Nar-Anon, and these will help with recovery. The Nar-Anon and Al-Anon are for family members. Even if your loved one that isn't going to an AA or NA meeting, you can go to Nar-Anon and Al-Anon and get help for yourself as a family member. All of these during COVID have been placed online, so all of these meetings are now available virtually. There are naloxone trainings, so if you think that you have a loved one who you need to be trained to know how to use that Narcan to save their life, they are available, and they have been doing those online during COVID-19 also. If you have prescriptions that are outdated or you haven't used all of the prescriptions, there are prescription drop box locations. Many of these are in front of police stations because they have to be monitored 24/7. We've got lots of references. So thank you for listening. And this is when I would be happy to answer some questions. And you can see that my email is below there. If you have anything that you would like to ask me, you can certainly email me.
Thank you, Judy, for that very engaging talk. We do have some questions, and a reminder to those who are still on the call that the question box is still open, and we can we'll be able to access any questions that are entered and hopefully have time to review them with Judy. So the first question is, what is the prescription monitoring program? I know you mentioned it, but can you speak a little more about it?
Sure. It's a statewide centralized database, and it collects prescription data about controlled dangerous substances such as opioids, human growth hormones, and gabapentin. That's the Lyrica that I talked about being abused. So anything that's been prescribed or dispensed in outpatient settings, the pharmacies. So they have to report daily to the prescription monitoring program the number of prescriptions that were filled. Prescribers, now your nurses, your nurse practitioners, your psychiatrists, they're supposed to look up patient records before they prescribe an opiate. And this kind of helps with not doing that doctor shopping. So if one doctor goes on, oh, well, you already have a prescription for this. So they're supposed to help with that. And then there are 15 other states that share the data with the New Jersey prescription monitoring program. So this prevents somebody from going, oh, I'm going to go into Pennsylvania and get a prescription, or I'm going to go to New York and get a prescription. It kind of prevents that kind of things.
Thank you. And then we have questions about opioid use during COVID. So the first question is there any current data? Is there any current data available about the use of opioids during this pandemic? And also, is the impact of COVID-19 that on current use due to lack of in-person support?
Well, I think that we're seeing, I haven't seen specific data, but I think in general, we're seeing an increase of alcohol use and drug use during COVID. People are bored, they're at home, they're self-medicating. They think if they use some of these things, it will prevent them from getting COVID. So, and whether they're using their prescriptions or whether they're buying it on the streets, drug sales are still up. So I don't have any specific data about how much more is being used, but my guess is that more is being used because of trying to self-medicate.
And here's another question. What increases a person's risks of overdose from opioids?
Well, they can, if they take more than, or they're prescribed, if they're supposed to take 1 pill a day and they're taking 2, that increases their risk. And also if they're, using it for a longer period of time. The longer you use it, the higher your risk of becoming addicted to it.
Can methadone be used during pregnancy?
Yes, methadone is FDA approved for use during pregnancy. Often during the 3rd trimester, a woman may need an increased dose. And if they can't tolerate the increased dose, sometimes they will have split dosing. But it's important that she doesn't feel any cravings. So we have to make sure that she's getting the right level. The baby will be born with methadone in their system and will need to be detoxed off a bit. But this is preferable to the woman losing her baby. We talked about how severe the withdrawal from an opioid is, and so she would run the risk of losing the baby. So on methadone, she's able to keep her baby, and the baby will have to be detoxed off of it, but that's the best solution at this point.
So to piggyback on that question, we have another one about babies. What happens to babies who are prenatally exposed to opioids?
Okay, so infants are prenatally exposed to opioids. If the mom is using up until the time she delivers, the baby will have opioids in their system, and they're going to go through withdrawal. With babies, it's called neonatal abstinence syndrome, or NAS, and the infant will be irritable, easily startled, have sleep difficulties. They may not sleep for long periods of time. They may have trouble falling asleep, have feeding difficulties. They may not be able to really keep everything down. It may come back up again and may need more often shorter periods of feeding. They have a high-pitched cry and tremors, and those tremors can last for quite a while. It's not like one day and those tremors are over. They can have sensitive skin where you have to make sure that all the tags are out of their clothes, or even sometimes put the clothes on inside out because they can't tolerate the seams. They can have vomiting and diarrhea. So a lot of times these infants need medication to help with the withdrawal.
What role, if any, does CBD have in pregnancy for pain management?
Does what? I'm sorry?
CBD?
Yeah, so if you had listened to Dr. Sabet's presentation, CBD can be used for pain management, but there's no regulation with it. Anybody can manufacture it, and there's a lot of adulterants in it that, so it wouldn't be my first recommendation because it's not a medical solution. It's, it can help, but you never know what's in it. Sometimes it has THC in it. Sometimes it has other stuff in it. So you have to be careful about whether you use that.
Thank you. And just for reference for the folks that are on the webinar, Judy was referring to Dr. Sabet's webinar from last week, which is Are We Going to Pot? And that is recorded and can be found through the partnerships YouTube channel. You can access it from our educational programs page. When is it safe to start having discussions with a patient who wants to potentially get off of methadone, or would it be safe to recommend that they stay on it?
I think it's an individual decision and one that they have to discuss with the nurse and their therapist at the methadone clinic, because everybody's different. Depends on how much they had to, what dosage they had to have. Not everybody has the same dosage. I mean, somebody that comes in using 1 bag of heroin as opposed to somebody that was using 4 bags of heroin a day, they're going to have different methadone doses. And they have to discuss that with them. It's different with everybody. There's just not one specific answer that can say, well, after 3 months, get off of it. And then it's an individual choice too. Some are afraid to get off of it, that they're afraid that they'll go back. So there's no specific answer that can say when it should happen.
Thank you. Does the fentanyl have medical uses?
Yes. Actually, there are some epidurals that during delivery, the epidural will have some fentanyl in it. It's been used to manage pain during surgery. And the forms, they can be an injection, a patch, a lollipop, a lozenge, or a nasal spray. And it's prescribed for chronic severe pain for things such as cancer or severe back injury or major trauma. So usually the patch is only used for those that can't tolerate the opioid therapy. And you have to be careful because what happens is if somebody takes that patch off and throws it in the garbage, somebody that wants to abuse it will take that gel out of that patch and try and get, because there's still some in there. But care has to be taken because there's a very little difference between a therapeutic dose and a deadly dose. So it really has to be monitored by a physician.
Thank you, Judy. Could you go back in your slides to the first page of the reference list? We've had some requests for people, they'd like to see it.
Okay. Which one? This one?
I would start with the first page and then maybe we'll advance it after the next question.
Okay.
Okay. What should someone do with an old or unused prescription?
This is where you take them to the prescription, to the drop boxes that I mentioned. Most of the drop boxes are located in by police stations, but you can go and look at that to find out where they are. They have to be monitored 24/7. So it can't be in front of a pharmacy that is going to close because an addict is going to try and break into it and get the drugs out of it. So most of the times they're by police stations, and you can drop them off, your unused prescription, your old prescriptions. And periodically the DEA and other programs will have a take back day that they'll advertise where you could take your pills and your prescriptions there. And then what happens is once they get all of these with the police stations, they take them to a special location in New Jersey, and I believe they incinerate them, because you don't want to flush them down the toilet because they are finding medications still in the drinking water. You don't want to wrap them up and put them in the garbage. You want to make sure that they are in a secure location. If you can't find a drop box, call your pharmacist, see if they will take any medication back.
Thank you. Can you go to another resource page?
Sure. Which one? The references or the resources?
No, resources.
Resources? Okay.
Okay, and I think we have time for one last question. What are some things that can be done to decrease opioid use?
Okay, so one of the things that you can do is use the use of the prescription monitoring program. That helps. You want to educate. You want to educate teens on the dangers of opioids. You want to educate parents so that they know what to be looking for. You want to decrease the number of prescriptions written. And like I said, a lot of physicians now are just doing it electronically. But we also want to decrease how many that they're doing with the opioids. And we want to be able to do that. We want to follow the CDC guidelines to prescribe the lowest dose for the shortest amount of time. We want to encourage physicians to use alternatives whenever possible so that they have better practices. We want to assist patients in weaning off instead of just stopping. And I think most physicians realize that they just can't stop somebody else. They have to help them wean off of it now. And we want to support research. The more research we have, the more education can go out there.
Thank you. I think that was a great summary. And that's all the time we have for questions today. I want to thank our speaker, Judy King, as well as Laura Hall, who's handling the technical back end of this program. A reminder that in about an hour, you will receive an email with a link to a post-program evaluation. Your feedback is important, so please take the time to complete. Certificates of completion will be sent via the email you provide on the evaluation, so please double check to make sure you entered the correct email. And you should receive those certificates within an email by the end of the week. Be sure to note if you require CADC, nursing, or social work credit. A calendar of the partnership's upcoming virtual programs can be found on our website, www.partnershipmch.org, under the Professional Education tab. We also offer on-demand recordings of many of the webinars we have been providing, and you can access those through the website as well. Our next webinar will be July 9th, discussing preterm birth resources and strategies to use with your patients. I hope you can join us. Have a good afternoon.